Here with Dr. Al-Ghoul. This is Clarity Laser Vision. Today we are talking about ICL surgery, or implantable columnar lenses. Dr. Al-Ghoul, can you give us a little bit of a history, what ICL is, where it goes in your eye?
For sure. So again, just a little background. Dr. Al-Ghoul, founder of Clarity Laser Vision. Our center is based out of Calgary, Alberta, and our philosophy is no compromise. That means that everything that we do is done with the utmost care pertaining to delivering the best outcome for our patients. So today we're talking about ICL. ICL is a type of lens that we insert into the eye to correct someone's vision. It falls under the category of what we call phakic intraocular lenses. So phakic means that we're putting a lens on top of your natural lens. So we're not actually replacing your natural lens. That would be something that we would do if we were doing refractive lens exchange, which we could certainly talk about at a later post. But today we will be talking about this idea of essentially putting what looks almost like a regular contact lens, but instead of putting it on the eye, you're putting it in the eye. Mm-hmm. So the technology has been around since the 80s through various iterations from various companies around the world. There's been a lot of different manufacturers, and when it comes to the actual lens, there's a company that put the lens on top of the iris, between the clear part of the eye, the cornea, and the, I'll show you here. So here's the picture of the eyeball. So you got the cornea, which is the front layer of the eye, and the iris. So the idea of a phakic IOL or this ICL essentially is this, the lens is put through a clear incision in the cornea, about 3 millimeter incision, and put in behind the iris. And it sits between the natural lens of the eye, which would be somewhere like here, and the iris. Now there's also another kind of lens where you put the lens on front of the iris, and you actually kind of hook it to the iris itself. But we personally have found that the ICL is a much more robust lens technology and a lot easier to put into the eye with less issues and complications in my opinion. So basically, as it stands now, the ICL, I'm going to show you a picture of what it looks like here, is this lens that basically, as you can see here in this model, it's a foldable type of lens. And the idea is you basically would put it, as I was saying before, between the iris and the lens. This particular lens from a company called Vision has been approved by the FDA since 2005. And there's been several iterations, with the latest iteration approved recently in Canada, actually, where we could correct astigmatism, and we could correct up to, I believe, minus 20 diopters of spherical error very nicely without having to do anything beyond just putting the lens in the eye.
Okay, so we have the one that goes on top of the iris and the one that goes in front of the natural lens.
That's right.
And in our office, we do the one that's mostly, we're going inside to the natural lens, kind of right in front there.
Yeah, the reason we haven't done the ones in front of the iris because traditionally you had to make about a 5 millimeter incision to put that lens, and I feel like the larger the incision, the more risk and variables there could be with the surgery. So with this particular type of lens, we are making a clear corneal incision that doesn't require any stitches or anything of that sort. And so usual procedure time is about 10 minutes per eye. And honestly, most of the time patients don't really feel much of anything. Occasionally feel a bit of pressure, but then that's usually about it. And then the recovery is a lot faster too because it's a smaller incision. Yeah.
Okay, and then with this technology, so the ones we do, it's called EVO, marketed as EVO by Vision ICL. So they have a really great patient website we'll direct you guys to. With this one, it has little holes for drainage, you mentioned. So we don't have to do any pre-operative for glaucoma or pressure management, right? There's no treatments?
Yeah, so yeah, that's right. That was what was recently approved in Canada. And they just recently got approval in the States as well. But what was unique about this particular model is that when you look at the actual lens, which by the way is basically like a,
Better.
yeah, it's a,
Yeah.
that's a better picture actually, yeah.
Yeah.
So there's a tiny hole right in the middle of the lens itself, which essentially have avoided the need to do any manipulation to the eye itself naturally. Again, with the other lens model that's out there in North America, you have to actually make a tiny opening in the iris to allow for fluid to kind of go through that. With this lens, you don't have to do any of that anymore, so you just go through a 3mm incision and the fluid can drain through this tiny hole that is designed now in the lens. So it makes it a lot easier as a procedure for patients to go through.
Would you say it's less risk then too?
Definitely, in my opinion, with this particular lens, I found that it's a lot more forgiving in terms of the thing we worry about with the ICL is that, you know, unlike LASIK or PRK, what we're talking about is this lens that we have to customize. So we're doing all these measurements to the eye, and then we're requesting the company to manufacture a lens that's customized to the patient's eye. So whenever you are going to calculate something, there's always a potential standard deviation, maybe slightly off one way or the other. But what we find with this particular lens model is that with the opening in the middle of the lens, it really does allow a lot more for, flexibility. And so far we found it's exceptionally rare that someone has to have that lens replaced. But we always talk to our patients about that risk, because it's just like a contact lens. Sometimes the contact lens may not sit right. Well, it's easy to replace a contact lens that's on the eye. But here, because it's an ICL in the eye, there's a risk of that potentially happening. But again, thankfully with this particular model, we found that, you know, we haven't really found significant concerns with that possibility.
Yeah. I'm glad you brought up kind of how it's like a contact, because one of the big questions we get from patients is they're almost concerned about the home care aspect. Because right now with contacts, you're removing them, you're disposing dailies, or you're cleaning them. So this is an implantable contact, we kind of say. So does a patient have any kind of maintenance? Are they having to clean any part of their eye or do anything special with it?
No, I mean, the thing is that it's sitting inside the eye, so you don't have to really worry about that sort of thing. But of course, like, I mean, I'm not trying to downplay the fact that it's still surgery and you got to be, you know, comfortable with the risks of surgery, right? But essentially, provided the lens is sitting nicely in the eye, this lens could last for as long as, you know, basically your eye's healthy. In other words, what I'm trying to say is that we're getting now patients who've had the ICLs decades ago, who now have lived long enough to develop cataracts. And they're still sitting in the eye, and basically at the time of doing cataract surgery, what we're doing is we're just replacing that lens, taking out that lens, putting in a new lens. So what I'm trying to say is that that patient had that ICL for their normal life, and now they developed cataract because they lived long enough and lucky enough to live long enough to develop cataracts, if you will. And now they're just going to have that ICL removed at the time of surgery. So they're very, very biocompatible is what I'm trying to say. They're very, very, very forgiving. But of course, whenever we put an ICL in our patients, we do want to monitor them closely initially for the first year to make sure it's sitting well. Then beyond that, we recommend once a year, which, I mean, I say that we should do that with all our patients, regarding what's being LASIK or PRK or ICL, just because, you know, this is a procedure, but then we want to make sure that the rest of the eye remains healthy from other things. So that's why we always recommend that your eye doctor continues to monitor your eyes normally.
Yeah, and that's part of our lifetime commitment to patients regardless. So we want our patients to be seeing someone every year just to maintain their enhancement policy that we have here. Because we will do enhancements for them, covered in their initial surgery cost.
That's right.
Yeah. So we had a question from a patient. Cody had messaged in. He already knows he's pretty much a candidate for ICL. He's -13 in the left, -15 in the right. And how would you know for a patient coming in? They know they're ICL, they know they don't qualify for LASIK or PRK, but how do we know if they are a candidate for touch-ups afterwards?
Yeah, so actually that's a great question. I just want to kind of bring up the point about ICLs and where we actually introduce ICL into our offerings, because, you know, as you know, we try to offer all the technologies that are proven to be effective for our patients. We don't want to kind of push one thing or the other. Our goal is to align the right technology with the right patient. So when it comes to ICL, Some of the things that we classically worry about are things like corneal ectasia and serious dry eye disease, for example, with patients who are coming in for certain, like LASIK or PRK, for example. So in certain subset of patients who are not suitable for LASIK or PRK, that's where we are talking about ICL.
Right.
So that's one category of our patients. The other category of patients that we offer ICL on is the ones who come in with a significant refractive error. So someone who's got, like, for example, more than -7, more than -8, they're hitting that sort of higher refractive error where we know
like
that if
Cody.
you did, like Cody,
Yeah.
so that's why I kind of wanted to connect that point to Cody's question, where we know that if you're going to do a laser correction, as we talked in our previous videos, there's a correlation between the amount of tissue you're removing with the amount of correction you're trying to do. So if someone's coming in with like -13, like Cody, that's going to require a lot of lasering on the cornea, and that certainly wouldn't be a good idea. And for that reason, we wouldn't be recommending like a LASIK or PRK procedure for him. But what's nice about an ICL in that scenario is that we would put the ICL, which essentially corrects the vision, and should there be a need for a touch-up down the road, typically the regression amount is not significant. We're typically talking about 1, 2, maybe 3 diopters of refractive error that's left over. And then we are more comfortable to do something like PRK on top of a patient who's had ICL, because we're only going to remove, let's say on average, I'm talking about 15 microns per diopter, so about maybe 45 microns of corneal tissue, give or take, which is within the reasonable range that you'd normally be willing to do something like PRK or LASIK, as opposed to -13, for example.
Right.
So to answer the question is, yeah, like typically for our patients who are getting ICL, we would offer lifetime commitment because we're very confident that, we're going to be able to, nail the target pretty nicely. And then if there's some deviations, provided that the cornea is still healthy,
right.
So they don't fall in that first category of someone who got, like, for example, risk for ectasia, then we could be very comfortable to offer something like PRK.
Okay.
Whereas if there's some irregularity like ectasia or something, then that becomes more of a case by case where we have to be very cautious on, talking about that.
Okay.
And that's why, although again, most of our patients do qualify for a lifetime commitment, we want to be, again, very clear about the fact that there's some patients who just aren't safe to have that. And in those categories, those are the cases we're telling our patients up front that look like, just to be clear, we wouldn't feel safe for you to have a laser touch-up because it's not the right thing for you from a health point of view.
Yeah, and you're counseling those patients after their whole 3 to 4 hour assessments and
as you know, with
testing.
Well, with ICL, it's like there's actually almost 2 layers, right? There's the initial assessment that we do, and then there's a whole set of tests, another layer of tests specifically
For the lens.
designed to measure the lens and make sure that everything else is appropriate for from a point of view of the candidacy of our patients.
Right.
So because it's an intraocular procedure, we are taking it very seriously. Of course, we're all our facilities are the highest standard to ensure we deliver the best outcomes from a safety point of view. But it's because it's an intraocular lens, we got to make sure that we do all the testing that we absolutely can to ensure the perfect precision and outcomes for the patient.
Right. So if someone has this lens implanted, and then say it was Cody, and then Cody needed an enhancement, would it be common for his prescription to, his correction to be pretty high, or would it stay on the lower amounts? What's the average amount that we see coming back?
So again, it's exceptionally rare that it would be a regression that exceeds 2 or 3 diopters. Most of the time it's within a diopter. And that's the thing we always want to know is, of course, if the eye is still changing, if someone coming in, their refraction is changing from year to year, then in our opinion, that's not a good candidate for corrective surgery because the eyeball is changing. Whereas if the eyeball has not changed much, if the refraction doesn't change much, then there's a good likelihood that the eyeball is stable. And therefore, for a regression to happen beyond a diopter or 2, it's usually very, very unlikely.
Okay. So, and then if a patient chose not to have an enhancement to their surgery, they would still be able to wear contacts?
Yeah, absolutely.
Or glasses,
usually.
or...
Yeah, like we did a patient of ours who he had about -17.5 spherical error, so it's with some astigmatism as well, and so he was in the category of patients who had actually a form of keratoconus or a cornea that was kind of somewhat irregular. So, our expectations were like basically that we're gonna try to make your vision a lot better, but we weren't going to necessarily aim for 2015 in that scenario because his cornea was already somewhat irregular but stable. So after a very thorough discussion, we had that understanding, and his outcome was pretty phenomenal. It was close to 20/20, but it wasn't perfect 20/20. But I mean, when you take someone who's like minus 17 and a half and you get him close to being 20/20, I mean, it's really, it's a whole different discussion than someone who's coming in with a -2, for example, where we of course want to offer technology that are far more precise for that patient, right? But if someone got already some irregularities to the cornea and they're minus 17 and a half or 18, then that's a scenario where we're setting a different kind of expectation for them. But of course, we've had other patients who had normal corneas, but high refractive errors with phenomenal outcomes as well. Like really, like 20/20 and 2015 outcomes. I just saw someone a few days ago with that, and in those cases, those ones are like would be more comfortable to say, yeah, if a touch-up is needed, no problem.
Right.
So.
Right. So would you find, because we're getting these group of patients that maybe they're not candidates for their traditional laser refractive surgery, LASIK and PRK, because their prescription is much bigger, would you say that maybe they're happier, in your opinion, after surgery? Or
from ICL, you mean?
Yeah.
Absolutely.
Yeah.
Absolutely. And this is the thing that's beautiful about refractive surgery is that we've been doing lasers for almost 30 years. And ICLs have been offered since the 80s. So we're at that stage where we have a lot of patients out there. They're estimated as about 900,000 people to date who have had ICL surgery.
Yeah.
So we're no longer at that stage of like nothing that we offer at Clarity is experimental or so early. Everything we bring in, we have to see clear evidence that's based on results, on studies, and also been long-standing with like lots and lots of cases. So like I say, with the case of ICL, although again, people don't really hear about it, it's been around for a fairly long time. Again, almost 1 million people have had it to date. But what was unique and what I would say has changed a lot in the last few years is the notion of being able to correct things like astigmatism, is the notion that you don't have to be doing any manipulation to the iris. So it really made it a lot more of a smoother experience for our patients. Which is why I believe EVO ICL is gaining more and more popularity in the North American market. In Europe and other places in the world, it's been around a lot more. And it's a lot more prevalent there. But in North America, with the advent of the EVO ICL, and especially astigmatic correction, we are now able to, truly correct someone's, spherical error and astigmatism fully in cases where they weren't candidates prior. And again, even a few years back, the astigmatic correction was with some manipulation of the iris, and now that we don't have to do manipulation of the iris after studies that proved its efficacy, and again, after lots and lots of cases, we are seeing that situation where we are taking a patient who's coming in for refractive assessments, and as opposed to, for example, 15, 20 years ago, if someone's got astigmatism, we would have said to them, look, I don't think laser surgery would work very well for you. But now astigmatism has become a very, normal thing to correct, especially with the advent of newer generation lasers like the ones we have. And then now on top of that, we have things like ICLs, and now we also have things like RLEs for certain segment of our patients who maybe are better candidate for having their natural lens replaced as opposed to having something like a phakic IOL or the EVO ICL put in.
Yeah, that brings up another question here. We had Mike. He's interested in ICL. He actually went on the Star Surgical website and found us through the directory as a surgeon who does it.
Right.
But he's 56 years old, and our website says we prefer 40 and under as candidacy for ICL. So he's wondering if this would be a good option for him.
Yeah, that's a good question. I mean, the thing about, that was sort of bringing me to the next point about the RLE model of doing vision correction. In other words, instead of putting a lens in your eye, you're replacing the natural lens with an artificial lens. We know in someone's lifespan that there's a good likelihood that if we live long enough, that was my point earlier, if we live long enough, we're more likely to develop cataracts. And we see that a lot because, cataract surgery is the most popular procedure being done in the world probably at this stage. And when someone's sort of in their 50s, we think that there's probably a likelihood that they're going to need, at some point, cataract surgery in the next, decade or two, or possibly 3 decades. So it all depends really on the status of their eye. If we see them and their natural lens is absolutely crystal clear and there's not a single hint of any lens changes that are potentially going to become cataracts in 10 or 15 years, then those are the cases where we would sort of tell them about the classic indication over the ICL, which is really up to the age of, I believe, of 45. Okay. And then beyond that, we would say it'd be considered off-label, provided that, again, they're comfortable with that and with the understanding that basically it's something that we would do only in certain cases. And occasionally we're always surprised. In my practice, I sometimes get 90-year-olds who have what I would say a 20-year-old lens in their eye, and I say to them, like, you have some incredible genes. It's like the retina looks absolutely crystal clear, the nerve looks clear, the lenses look clear. They must have done something right in their life to have that happen. So I would say those are kind of unique cases. Once we hit sort of that age limit, we talk about it case by case.
Okay. Is there a risk that implanting a secondary lens like an ICL can give us a cataract?
Of course, and those are so that takes us to the next point of risks with ICL, which is a good point to bring up. So the things that we worry about with the lens that we're putting, of course, in the eyes are things like trauma to the lens itself causing cataracts, issues to the iris causing like pigment dispersion, or in other words, risk for what we call glaucoma, where the pressure can go high. Right. Potential risk to the cornea itself, the endothelial cells. There's always risk of things like infections or retinal tears, detachments. All those things are possible. Again, really exceptionally rare, but those are the things that we'd have a more detailed discussion with our patients about.
Right. Okay. And then as far as dryness goes too, that's always something that we think about with refractive surgery. The Discover ICL site actually talks about the biocompatibility of the lens and how that contributes to less dry symptomology. True?
True. And what I would say is that when we see our patients, that's one of our decision-making points, right? And that's, if I go back to my point about aligning the right technology with the right patient. So, I really truly believe that every eye is unique, and you can't really just streamline everybody through one technology. So if we get a patient who's got, for example, significant dry eye disease that we manage, control, but we still concerned about it, we could have a discussion. We, in fact, do have discussions sometimes with them about ICL being less likely to induce dryness than, say, something like potentially LASIK. And often what we're doing is we're sort of categorizing the risk, the benefit and risk of the various options. And certainly when we talk about ICL, we do mention it having one of the least risks of causing dryness because we're not making much incisions into the cornea itself where the nerves lie. And so, that's a point that we definitely bring up when someone comes in with dry eye disease. If it's a serious issue, of course, we wouldn't do corrective surgery. But if they're manageable, if they're treated, and they were thinking about it, potential corrective surgery, then we'll bring that up as an option.
And then what about someone, this is the last question we have for the night, if they are interested in looking at police, military services, is this an acceptable correction for their eyes?
To be honest with you, I don't remember. I believe it is, but I have to remember the exact specification because every profession has their own criteria.
So it depends which exact.
So it depends on which. So it depends on which profession we're talking about. So that's something where if someone's interested in the police force, we usually tell them, well, then give us, for example, what they're comfortable with. And so, of course, as technology evolves and changes, then they're more likely to, of course, to adapt to that as well. But for example, certain professions are perfectly fine with ICLs and others would be a bit sort of on the fence. So it's a case-by-case basis again, where it depends on the profession that you're going after as to whether they would allow for ICL technology or not. And that's, again, easy information you could find from any any professional organization that represents that profession. They'll have, usually every professional organization will have a guideline that talk about sort of what's acceptable and what's not.
Awesome. So still come in for a consult and we'll see. So just kind of a summary here. So typically for our patients, we're looking for someone roughly over 20, like our cap. You have to be over 18 for refractive surgery. So we're looking around 20 to 45 for ICL, and we can go up to -20. And then the specs here from the site says they go up to +10 for prescriptions as well. And now we can correct astigmatism with these lenses, so definitely a lot more options for patients if they're not a traditional candidate for LASIK and PRK.
Yeah, it's been fantastic, and yeah, I encourage you to come and come and see what we can offer you. And we'll definitely have a very detailed discussion about all the potential options that are proven to be a benefit for our patients.
Yeah, sounds good. So we're not going to do another Facebook Live for this year.
That's right.
So this is signing off.
Our last Facebook for 2018.
Yeah, we'll
Fantastic.
have to, we're going to pick up, I guess, in the second week of January we come back, and then we'll let everybody know when we'll be on here next. Have a happy holidays, everybody. Enjoy your new year. Stay safe, and give us a call if you have any questions about the ICL. www.claritylaservision.com. The number is 403-640-0400. Thanks, guys.
Take care, guys.